Welcome to this MedUni Nursing lecture on post-procedural nursing care. Today we are focusing on 3 important devices nurses commonly see on the ward and in acute care areas: chest drains, suprapubic catheters, and tracheostomy tubes. Before we start, ask yourself, if one of these devices suddenly stops working, falls out, blocks, or starts bleeding, would you know what to do first? This lecture is not about inserting these devices. It is about safe nursing care after the procedure. Your role is to recognize what is expected, what is not expected, and when a red flag means you must escalate immediately. The key message is simple: patient first, device second, red flags early, escalate safely. By the end of this brief lecture, you should be able to perform key nursing checks after common procedures. You should be able to identify red flags before the patient becomes critically unwell. You should also feel more confident escalating concerns using an ABCDE approach and local hospital policy. As a nurse or nursing student, you are often the first person to notice that something has changed. So throughout this lecture, keep asking, is the patient stable? Is the device working? Is there a red flag? And do I need help now? Before we discuss individual devices, let us start with the basics: infection prevention and documentation. For chest drains, suprapubic catheters, and tracheostomies, clean and safe care matters. Always perform hand hygiene. Use gloves and PPE when required. Use aseptic technique for dressing changes or device care according to local policy. But do not only look at the device, look at the whole patient. Check the site, check the tubing, check the output, check pain, check observations, then document clearly. Record what you found, the time, your initials, and what action you took. But here's the important point: documentation is not escalation. If you are worried, do not just write it down, escalate it. A chest drain is a tube inserted into the pleural space. It removes air, blood, fluid, or pus from around the lung. You may see chest drains in patients with pneumothorax, pleural effusion, hemothorax, empyema, or after chest surgery. Now pause and think. What is the biggest danger if a chest drain blocks, disconnects, or falls out? The patient may deteriorate quickly with worsening breathing, hypoxia, pain, or recurrent pneumothorax. Your nursing role is to monitor the patient, check the drain system, observe the output, and recognize early signs that something is wrong. After chest drain insertion, start with the patient, not the bottle. Ask yourself, is the patient breathing comfortably? Check respiratory rate, oxygen saturation, work of breathing, pain score, and vital signs. Then check the insertion site. Is the dressing clean, dry, and secure? Is there bleeding, swelling, leakage, or surgical emphysema? Now follow the tubing from the patient to the bottle. Are there kinks, loops, disconnection, fluid trapped in the tubing? If your system allows it, observe swinging and bubbling. Gentle swinging may be expected. Continuous bubbling may suggest an air leak or loose connection. Finally, check the drainage amount and color. And remember, the chest drain bottle must stay below chest level. This is one of the most important chest drain safety rules. The bottle must stay below the patient's chest level. Do you know why? Because if the bottle is lifted too high, fluid may flow back towards the patient. This matters when the patient mobilizes, sits out of bed, goes to the toilet, or changes position. So ask yourself every time, where is the bottle? This is a very important slide. If the patient suddenly becomes breathless, hypoxic, distressed, or has increasing chest pain, do not focus only on the drain. Go back to A, B, C, D, E, and call for help early. If there is no swinging or no drainage, ask, is the tube kinked, blocked, disconnected, or sitting in a dependent loop? If there is continuous bubbling, Think possible air leak or loose connection. Check the system and escalate if it continues. If there is large, fresh blood drainage, treat it as serious internal bleed. Check vital signs and escalate urgently. And if the chest drain falls out, this is not a wait-and-see situation. Cover the site immediately with an appropriate dressing, give oxygen if needed, assess the patient, and call urgent medical help. Detailed answers are provided in the handout, which is free to download. A suprapubic catheter is a urinary catheter inserted through the lower abdomen directly into the bladder. It drains urine without passing through the urethra. It may be used for urinary retention, urethral problems, long-term bladder drainage, or after some urological procedures. Now pause and think, what would worry you after suprapubic catheter insertion? No urine output? Severe lower abdominal pain? Fever? Leakage? Bleeding? Catheter falling out? These are important red flags. Your role is to monitor urine output, check the catheter site, maintain a closed drainage system, prevent infection, and escalate early when something is not right. After suprapubic catheter insertion, again start with the patient. Is the patient comfortable? Are they in pain? Are the observations stable? Is there lower abdominal discomfort or bladder distension? Now check the catheter site. Is the dressing clean and dry? Is there bleeding, swelling, redness, leakage, or discharge? Then check the tubing and drainage bag. Is the catheter kinked? Is the bag below bladder level? Is urine draining freely? Record urine output, color, and clarity. Here is the key question. Has the urine output suddenly stopped? No urine output? You cannot ignore. It may suggest blockage, displacement, dehydration, or bladder distension. If you are concerned, escalate. This is another important red flag slide. Red flags include no urine output, severe lower abdominal pain, catheter blockage, catheter falling out, bleeding, fever, rigors, urine leakage, confusion, or signs of sepsis. If there is no urine output, first check the simple things: tubing, kinks, bag position, and bladder discomfort. But if it does not resolve quickly, escalate. If the catheter has fallen out, do not attempt reinsertion unless you are trained and local policy allows it. The tract can close quickly, so cover the site and call urgent urology or medical help. If the patient has fever, rigors, confusion, fast breathing, low blood pressure, or looks very unwell, think sepsis. A tracheostomy is an airway through the neck, with a tube placed directly into the trachea. It may help the patient breathe, clear secretions, receive oxygen, humidification, suction, or ventilator support. Now pause. Why is tracheostomy care high risk? Because this is the patient's airway. A blocked or displaced tube can quickly cause respiratory distress and hypoxia. So your first thought should always be airway first, act fast, escalate early. With a tracheostomy patient, start with breathing. Ask yourself, is the patient comfortable or distressed? Is the oxygen saturation dropping? Is there noisy breathing or increased work of breathing? Check air entry, respiratory rate, and oxygen delivery. Now check the tube. Is it in position? Are the ties secure but not too tight? Are secretions thick or increasing? Check the stoma and dressing for bleeding, swelling, redness, discharge, or infection. Make sure humidification and suction are available and working. Finally, check the emergency equipment: suction, spare tracheostomy tube, smaller tube, and airway equipment. Key message: with tracheostomy patients, emergency equipment is not optional. His is a high-risk slide. Pause and ask, is the patient suddenly distressed? Is the oxygen saturation falling? Is there noisy breathing, reduced air entry, or increased work of breathing? Think blocked tube, displaced tube, or airway obstruction. A mucus plug can be an emergency. If you are trained, suction and check the inner cannula according to local policy. If the tube falls out or is displaced, call emergency help immediately. Oxygenate the patient and prepare airway equipment. Bleeding from the stoma or tube is always important. Feel swelling or crackling around the neck or chest? Think subcutaneous emphysema and escalate urgently. Fever, redness, swelling, pain, or offensive secretions may suggest infection. Red flag rule. With tracheostomy problems, do not wait. Airway. Let's bring everything together. Chest drain, suprapubic catheter, or tracheostomy. The approach is the same. Patient first, device second. Red flags early, escalate safely. Pause and ask yourself, is the patient deteriorating? Is the device blocked, displaced, leaking, or bleeding? Is there infection, severe pain, breathlessness, or no output? Do not be reassured by a device that looks fine if the patient looks unwell. When escalating, use SBAR. Who are you? What is the problem? What are the latest observations? What is the device status? What have you already done? And most importantly, what are you worried about? Escalate clearly, document accurately, act early. Thank you for watching this nursing lecture. Safe post-procedural care is not just about checking the tube, drain, or catheter. It is about recognizing patient deterioration early. Before you leave the bedside, ask yourself, is the patient stable? Is the device working? Is there bleeding, blockage, displacement, infection, severe pain, breathlessness, or no output? And the most important question, do I need to escalate now? Remember, patient first, device second. Red flags early, escalate safely. You can also download the lecture notes and practice MCQs to test your knowledge. The link is provided in the description and pinned comment. Thank you for watching.